join us. So welcome everyone to our May Teach Educational Rounds. Here with us today, we have Dr. Allison Crawford and Dr. Peter Selby, who will be presenting on strategies for suicide prevention in primary care. We are going to begin with KMH's land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the Council Grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I invite everyone to introduce themselves in the chat and let us know which traditional territory you're joining us from today. If you're not sure, I'll put that link in the chat for you to find out. You're also welcome to share something that you're doing to learn or improve your commitment to reconciliation. And while you do that, I'll also just share a bit about myself and my positionality for those that are joining for the first time. So my name is Natalie, and like KMH, I'm currently located on the lands of the Mississaugas of the Credit. I'm of Italian descent. My grandparents arrived in Canada on a boat from Italy in 1958. I've lived in the city of Toronto for almost 2 years now, where I've grown to truly appreciate the community and the vibrancy that this land has to offer. I acknowledge the privilege I have as a white settler to live here and be within close proximity to all my daily needs. And as someone with type 1 diabetes, I'm particularly grateful to have access to insulin and all my other required medical supplies and treatments. So I myself am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard and reflected within my work and personal life. So I know not many have had the chance to share yet, but please do keep sharing in the chat. We love reading through all your comments. In the meantime, I will continue on with some housekeeping items. We do have a very exciting announcement today. So to reflect our diversification of projects and programs since our inception, the nicotine dependence service here at KMH will now be known as Intrepid Lab, which stands for Innovations, Nicotine and Tobacco Research, Education, Programming, Implementation, and Digital Health. So we're very excited about this rebranding and continuing to work with all of you. Just note that this does not mean that the TEACH program name will be changing, and it will not have any impact on any future or current TEACH courses or trainings. If you do have any questions, though, feel free to contact us at intrepid.lab@kmh.ca. So thank you. And if you're interested in receiving a letter of completion for this TEACH educational rounds, please make sure you have registered for the webinar and completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track your participation. And last but not least, make sure to complete the evaluation and post-learning assessment by the end of the day, by next week, if you're interested in a letter of completion. Along with that, we will also be sharing a copy of the slides and the recording if you would like to review afterwards. So here's a little bit more information on our presenters today. First up, we have Dr. Peter Selby, who is a senior medical consultant and a clinician scientist at KMH. He's the interim vice chair of research, Giblin professor, director in addictions and mental health division for the Department of Family and Community Medicine at U of T. Full professor in the departments of psychiatry in the Dalla Lana School of Public Health, and a clinician scientist in the Department of Family and Community Medicine. So welcome, Dr. Selby. We're always fortunate to have him join these sessions. And here's just his disclosures to report here. I'll give you a second to read through those. And next up, we have Dr. Allison Crawford, who is the Chief Medical Officer for the National Crisis Line Talk Suicide Canada. She's also Director of Virtual Health, Mental Health and Psychiatry Outreach at KMH and Associate Professor of Psychiatry at U of T as well. So welcome, Dr. Crawford. And no disclosures to report on her end. So please note that the content of Teach educational rounds are centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenters. To do this, just click on the speech bubble icon in the control panel and ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. You're also very welcome to use the reaction feature if you'd like to send a smiley face or thumbs up or anything like that throughout the webinar. So with that, I will hand it to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Thank you, Natalie, and really pleased that Dr. Crawford is with us. I'll just do a quick overview from the STOP side and how we arrived here, and then hand it over to Dr. Crawford to take us to the next level. Now, I'm going to try to see if I can change the slide, but I don't think I'm going to try. Are the slides moving? Perfect. Okay. So, in the next hour that we have together, shortly less than an hour, what we want to do is really get 3 learning objectives. Explain the importance of screening for suicidal ideation in primary care, describe how to assess suicide risk, and then apply interventions to support clients who identify suicidal thoughts, intent, or in crisis. And this goes beyond, this is obviously we've learned it from STOP, but it goes beyond that. So what is the role of primary care in suicide prevention? Frontline practitioners in primary care, so whether you're the nurse or the nurse practitioner or the physician or the pharmacist or the healthcare worker, whoever there is, we are in a unique position to help prevent suicide and detect manage suicidality, because people who attempt or die by completed suicide were in touch with primary healthcare services. So there's an opportunity for us to intervene. 80% have had contact in the 12 months prior. 44% of general patients and 97% of older adults have been in contact 1 month prior to suicide. So there's something for us to, is it possible for something for us to do? Because again, as we think about suicide, there's sort of risks that there are, but there's also impulsivity involved. But in general, if there's contact, again, is there something for us in the primary care sector to do? So, we had, as part of the STOP program, as you know, when people came to quit smoking, we realized that people have high levels of comorbid mental health conditions, even in primary care settings. So I think a good example would be Jamal here, who's 46-year-old, identifies as male, started smoking as a teen, smoking 20 cigarettes per day. And, we are really wondering what has happened in terms of their overall smoking, because as you know, people who continue to smoke today and continue to be smokers are much more likely to be less than high school educated, have work in, be unemployed or work in blue collar jobs or in jobs that don't pay much, and tend to have comorbidities like mental health conditions. So there's a lot of things going on when you're trying to help somebody quit smoking compared to maybe 50 years ago, where smoking prevalence was much higher. So I got interested in this topic of smoking and suicide and reading a paper about 10 years ago or so, where there was this paper that came out that sort of identified smoking as an independent risk factor for people dying by suicide if they had bipolar disorder. So I started looking further into it and started realizing that, when we take a look at papers were coming out for a long time about this association between smoking status and suicide, and so we really started paying close attention to it. And so this meta-analysis, which has brought together many studies together to look at it and look at what are the the odds ratios of in current smokers and former smokers of these phenomena on the left-hand side, the suicidal ideation, suicide plan, suicide attempt, suicide or death by suicide. And you can see there's almost this, um, dose response in the sense that if you're currently smoking, your risks are doubled for ideation, and it's slightly lower if it's a former smoker. But of course, you can see some overlaps in the confidence intervals. And planning is the odds ratio is 2.36. Suicide attempt is 2.84 versus 1.4, and death by suicide is 1.83 versus 1.33. So there's something there, and it's not clear why that is, but there certainly is this association between these two factors. So as part of this, we think about, go back to Jamal, typically somebody has enrolled, they have been quit for a couple of weeks. And as we know, people who quit there's nicotine and the 7,000 chemicals in a cigarette have many compounds that affect the brain, including something called MAOI inhibitors. So the body is readjusting to not having all these chemicals in the brain. And psychiatric symptoms can emerge either as part of withdrawal, or underlying psychiatric symptoms can also emerge. However, we do know that people with low levels of nicotine dependence have lower odds of suicidal thoughts and attempts compared to people with high nicotine dependence. Again, when we're starting to look at associations between two variables like smoking and suicide, if one goes up and the other goes up, and one goes down and the other goes down, that helps make the case that there may be something that one is causing the other. And this case, obviously, smoking being a risk factor for suicide. Now, one of the things is that it's not, obviously it's not just simple as that, but because that phase of when people quit can precipitate a clinical depressive state, especially in people who've had depression in the past. And it is plausible that people get, tipped over and have acute nicotine withdrawal that either is manifest as depression and or an underlying depressive condition. And now that person now feels and emerges with suicidal ideation. So that's also another possibility here. So let's take a look at the data. Based on what we were seeing in 2018, a suicide risk assessment protocol was implemented in the 123 family health teams to assist with and identify and triaging individuals at risk of suicide. And here's why. We know people who smoke, if they have a depressive illness, they are less likely to be successful. So we wanted to make sure we were helping practitioners identify that. And there's an instrument called the PHQ-9, which has 9 questions. And when we looked at the literature, what was happening is, one is that people were either skipping the suicide question and just asking the PHQ-8 because they don't want to deal with the issue. And when we looked at it, we said, well, that wouldn't be ethical to just skip it. What we really need to do is to help the primary health care team, one, get comfortable with this part of it and, address it like any other thing you would address. I mean, if we just by burying our heads in the sand, that wasn't an answer. So we said, no, we're going to be bold and we're going to lean into it, but we also want to make sure that there are supports. Because we had 38% of people participating in STOP, coming to quit smoking, had a current depression or past history of depression. And when you looked at their quit rates, again, you looked at their quit rate was about 7% less on average versus those who didn't have depression. So, and this was published by one of our scientists, Dr. Nadia Minian, based on the findings from our study. So really, we felt that this risk assessment had to come in as part of it. And as part of that, that's where then we decided that we should do this risk assessment. And that's where it all started. And there was a wide consultation done, but I'm going to now move it on to Dr. Crawford, because she's going to take it on and talk about, based on her expertise, how we should be assessing risk. So over to you, Allison.
Thank you so much, Peter. And it's really great to be here. In the next section, what we're going to do is go over a little bit of how to understand risk and also protective factors across different populations that can be considered within primary care or really any setting. And then go through 3 cases. One that's sort of a lower end of risk moderate risk, and higher risk, and just talk together about how you would manage those things in primary care, and hopefully poll the group and get some feedback about what you would do in that situation. All right. Can I actually change the slides? Did Peter figure that out?
Yep, you should be able to see the little arrows at the top of the screen.
Oh, fantastic. Okay, so if we go back to Jamal, who Peter introduced the scenario of Jamal, and these are some of the things that probably stood out to you. You know, change in his mood, fact that he had experienced depression in the past, increased alcohol use, drinking above the guidelines, and recent loss as well, and also his social isolation. So all of those things are kind of pulled out at the bottom. They are all risks associated with, certainly risks for mood disorder, for depression, and also risks for suicide. And I'm going to go over kind of a model for thinking about those risks. Okay, this looks like there's a lot going on here, but I'm going to pick some highlights. Often when we think about people who end up attempting suicide or dying by suicide, a lot of the models look like what you see at the bottom, kind of a pathways model. And they focus on the accumulation of different risk factors. And we don't have a nice, neat model that shows which factors, well, I can tell you which factors are most concerning, but that's the most common model, to sort of plot that out on a pathway through someone's life. We know there are genetic factors, epigenetics, because not everyone who has those genetic factors ends up being at higher risk. So the things that happen in early childhood. And so we think of those as more upstream risks in people's lives. It's only recently, like probably the last 10 to 15 years, that we even talk about upstream risk and suicidality. It's still not a huge focus of intervention, but we certainly know there are risks if people experience a lot of adversity or trauma or attachment disruption in their early life. And especially if they also have that genetic risk factor, then that becomes an epigenetic risk. And then moving and also living in certain circumstances, also a more recent focus in terms of suicide prevention. Often when we think about someone who's at risk for suicide or showing up talking about suicidality, that clinical view onto that person helps us think in a very individual way about their mood symptoms, about their alcohol use, all the things that we know are important. But it's only more recently that we think about their kind of larger social context. Things like socioeconomic risk factors, health inequity, sexual orientation. We know that certain groups have higher risks. So those are both upstream and then ongoing risk factors. And then acute risks and stressors. This is where we usually really start to pay attention to risk factors. So are there other mental illnesses, comorbidities that we know are associated with suicidality, like bipolar disorder or depression, other mental health disorders? Certainly, if there are disorders, either physical or mental health disorders, that have an impact on cognitive function, that can actually, people lose inhibitory control. So things that are risks become even greater risks. The same thing with substance use can increase impulsivity. And then current life stressors. So we often see in people's trajectories that they have a lot of this risk, but then it's really under stress, stress caused by financial distress, relationship loss, that can really precipitate suicidality. And that's why also this diagram really shows that in the moment, if you're assessing if someone's at risk, all of these factors really are at play. Okay, but what are the most significant risks? And I think about this in two ways. One is like, what really should alert you to think, okay, we know that these are risk factors. So if I have someone in front of me that has a certain profile, maybe I'm going to think more about assessing suicide risk. But the second way I think about risk factors is what's modifiable. So we know that gender plays a huge role. We're really, that's not a modifiable factor. If someone's had a loss, there's certain things about it that are modifiable, but the loss itself isn't. But these are the most significant risk factors from that whole mess that I just showed you. So certainly male gender, except in certain populations, including being a physician, where rates for women are also high, and then in certain other subpopulations. But definitely overall being male, being widowed, divorced, or separated, so partly through differences and changes in social support. Same thing, being in a lone person household, being unemployed, and especially with income uncertainty is a big risk factor. And that may be different in different groups. I'm going to talk about that in a few moments. And this data came from fairly recent data from Australia. Okay, but I also think this is very important, especially when we're thinking about the person in front of us and how to understand their experience. So we've got risk factors, but then we also, to really understand why people, lots of people have those risk factors. What actually moves someone from having those risk factors into contemplating suicidality? And this interpersonal theory of suicidal behavior, Van Orden, Thomas Joyner, people like that have really brought this to the fore. So we can have people who have a desire for suicidality because of, and the two interpersonal factors that are highlighted are feeling that they don't belong. And they call this thwarted belongingness. So really feeling, I don't have anyone, I don't have a place, I don't have a sense of meaning. And then perceived burdensomeness at the same time. I'm too much for people, no one can help me. That combination can kindle the desire for suicidality. And then once you introduce the capability for suicide, that is when you get lethal and near lethal suicide attempts. So I think of this as a layer on top of all of those other biopsychosocial risk factors that we know of. And I find that this also helps me, in a conversation to really understand where someone is coming from. All right. So we talked about Jamal. We're going to switch here to Janine to just think a little bit about also thinking about strengths and protective factors. Also something that we've seen change a little bit in assessment. Probably all good clinicians, we're always doing this, but we talk in suicide prevention so much about risk factors. But understanding someone's strengths are also important. So this is Janine, who's 33 years old. She's got pregnant, has two other young children, also a caregiver, so that classic sandwich generation, caregiver for her mom. But she does have some siblings who provide support to one another and to her mom. She realizes that when she has a lot on her plate, she can get help. So not only does she have support, she's also likely to reach out for support. She also started to make a list of what her mother needs, what each of her siblings can do to help. So you get the problem solving. So she's got good problem solving skills, and also support and affiliation with a religious organization, which is actually quite protective for people as well. So you can see highlighted in blue that these are some social support, absolutely critical, likelihood of that the person will reach out for help, problem solving skills, but then also like impulse control. Impulsivity is also a very big risk factor in suicidality, but somebody who's really using that problem solving, using their executive functioning, not impulsive in other areas of their life. That is a really important strength, as well as affiliation. And you can think about this on multiple levels, including that interpersonal approach that I showed you. Okay, so we're going to come back to those cases again, but really thinking risks and strengths. Now, I put this in here because I know the question of screening often comes up. Peter already mentioned the PHQ-9 to screen for depression. And in Canada, there's no clear evidence for universal screening for suicidality in primary care. I say that with care because at the same time we know it is, like Peter was saying, a really unique opportunity. in primary care, you're seeing people all the time. You're seeing them at their most vulnerable points in their life. I would say it's important to have it in mind and to screen when, you know, it's going to make you more perceptive. I'm sure you're already perceptive, but make you more perceptive about someone who might be at risk. But to say that, like, we're not saying that you should just screen everybody. Another caveat is that some of the tools that are available, there are all kinds. Oh, I see someone actually just put it in the chat. Thanks, Sarah. Yeah, about the Columbia Suicide Rating Scale, also very commonly used. So I didn't pick one versus another, but just wanted to address this issue of screening. Screening is an imperfect science. Obviously, it's not predictive. We definitely don't want people to screen and then think, oh, great, the screen was negative, the score was this or that. We can put it aside. It's really a tool in the context of an overall relationship and assessment. And where I do find it helpful is, you know, understanding someone's sort of baseline and when there are changes to that baseline, and as an opportunity. Sorry, it's very loud outside all of a sudden. It's that season of lawn mowing. So within the context of a relationship, it helps you to ask about it. Having said that, this ask tool, so this is developed by the NIMH in the US and has actually quite good properties. It's very simple to use. It started around screening for youth, but it's also been validated in adults. But again, I don't have a particular opinion. Sarah, whatever screening tool people like. This one's very easy to use in primary care, but some people are more comfortable with other tools, with all the other caveats that I talked about. And this is often used in conjunction with the PHQ-9 in research as well. So you can see the questions there. In the past few weeks, have you wished that you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? So again, burdensomeness. In the past weeks, have you had thoughts about killing yourself? Have you ever tried to kill yourself? And you'll recognize in those questions some really basic questions that we would ask in any suicide risk assessment. You only ask the fifth question if there's any positive screening questions 1 to 4. So are you having thoughts of killing yourself right now? And that's a question about imminence of risk. So is this something you should be concerned about right now? And they do put some guidelines in there about what kind of assessment you should do next. I think you could think about this. We're going to go over these 3 cases that I keep promising you, low, mid, and higher range of risk. And you could almost think of these questions in the same way. Somebody who answers yes to one of the 1 to 4 and yes to 5 would be at the higher end of risk because there's some imminence there. Someone who answers no, obviously you may still have worries about their mood or their substance use or any other number of things, but if they answer no to every question, they're going to be on the lower end of the risk. And then if there are some yeses, but no to number 5, they're sort of somewhere in the middle. But you can hear from the way I'm presenting it, there's not a huge science to whether someone is low, medium, or high risk. Obviously, there are some red flags that are definite high risk, like imminence of risk or an escalation in recent attempts, but it's really the overall picture that is important. All right, I want to get to these cases. Now, sometimes we hear from people, I do want to ask my patients, I want to be a resource, or I do want to ask my friends for that matter, or my family members, but it's how do we ask? So again, this is one advantage of screening when you have a concern or using a screening tool that can be helpful, and also being direct. So having a relationship already with people, which is such a big part of primary care, but really just starting with how are you doing, and to say, I'm concerned about you. I'm concerned because you just quit smoking, for example, in Jamal. I'm concerned because you're very sad. I'm concerned because you've been through a lot, whatever the risk is, and then asking directly, are you thinking about suicide? That kind of direct, there's no evidence that asking directly increases risk in any way. So we should never be afraid to ask and should ask directly. And of course, if the other point of entry that's noted here, if the person is screened positive, that can be another entry into that conversation. Okay, and this follows along from some of the things that Peter was saying earlier, this can come up as well. So you've noticed an association or a risk, like the fact that he's quit smoking, but that may, if you go on to ask him about suicidality, that might not be so obvious to the person. Again, psychoeducation, saying, it's important that we look at people who are, as they're trying to quit, also have low mood, because we know sometimes those people need extra support. So really, this is a bit of, well, Peter's the expert in motivational interviewing, but that's what sprung to mind for me, really doing the psychoeducation and then supporting their decision making so that it's obvious why you're making the connection with suicidality. This we've mostly covered. It's more of a list that highlights some of the things I've already mentioned, but different ways you can take the conversation. So one thing that is really important, we know that past attempt is very important. Recent attempt is even more important. And escalating attempts is something we would be of concern in any population. So we often get questions like, well, this person has attempted suicide before, like, how do I know? We'd use different ways to describe this, like acute on chronic risk, but even in somebody who has frequent suicide attempts, if they are in a very stressful life situation and have an escalating pattern of attempts, that would increase our concern for sure. If they have a plan, method, steps taken towards those plans. So you would go into these questions if you had any positive screen, either in a formal screening tool or through your conversation with that person. These are additional things that you would want to know, especially access to means. That is very important because that's a very direct step that can be taken to decrease risk. So we hear about, people working with equipment in their jobs, guns, of course, access to guns, access to medications, including prescription medications, access to fertilizers, anything, especially if it goes along with their plan, asking them, once you understand if they have a plan, if they have access to means. Substance use definitely increases risks. Comorbid mental health challenges, so that's something that should be assessed alongside. Understanding their beliefs and thoughts around death can be helpful, and really thinking about it again in that interpersonal conflicts context. What is causing them pain, and is there anyone to support that? And some other strengths are mentioned there. Okay, we are actually getting to the cases now, and thinking about the interventions. So I'm going to start us off just thinking about some very basic interventions. Anything we do is an intervention because it can really make the difference between somebody with a desire and capacity and moving on to behaviors. And then when we go through each case, I'd love it if we have some time to put some things in the chat. So I think it starts right from the beginning. Both the risk assessment and the intervention starts right from the beginning. That authentic connection, the caring and support that you offer can really make a difference. Validating someone's feelings. So we're careful here. We don't validate the fact that we don't validate suicide, but we certainly can validate what makes sense about it. It makes sense that you're suffering right now. It makes sense that you want a way out. Validate what can be validated. And then in general, collaborating with the person. There are times we have to intervene. There are times we have to use the Mental Health Act. We have to do things that are involuntary, but we certainly throughout try to collaborate with them. What can be put in place? Do you have ideas? What do you think are the main risks here? Really having that stance of collaboration and respecting the person's autonomy as much as possible. Okay, so going back to Janine, because she has so many strengths and because she has said that she's has thoughts about dying and suicide, but not actually a plan, and there were no other risk factors identified. So we're thinking she's on the lower end of the risk. At the same time, she is, pregnancy, postpartum period. We know that those are risks. So you've got that in your mind, but you've done the assessment and she's on the lower end of things. Now, there is a list right here of things that you could do, but just curious about what you would do. So you've got this, I think this woman who's in the perinatal period, has other young children, does have some coping that you've identified. What are the things that you would do first? And if you don't mind you could start popping those in the chat and we can see a list. It's not super interactive because I can't see you, but would love to hear any ideas about what you would do in this situation. Yeah, ask who else is in her circle of care. Thanks, Janice. I think this is actually another part of the beauty, the practice-based evidence is that addressing this in primary care is super important because there is hopefully, especially if someone has an NP or a primary care physician or other member of the team, that there is a team there, and that can be very helpful to stabilizing people. Yeah, and also asking to speak with them so that you can see up here, getting additional history, very important. And asking directly. I think this is something, I know on the crisis line, so you think like a crisis line gets started, it's a suicide prevention line. People have 4 specified questions they have to ask about suicidality. You know how often they get asked? 50% of the time. So even in a context where people are doing suicide prevention, know the questions to ask, they don't always ask them. So I think that is extremely important. Asking within the context of that relationship very explicitly, are you thinking of suicide? I'm concerned about you. And do you have a plan to end your life? Yeah, thanks, Diane, acknowledging it must be tough. So the validation, ask her what helps her stopping her for acting on this. Yes, absolutely. And I think that's why with Janine, that sounds like that was part of the conversation about, what are some of the supports and strengths that she has. Absolutely. Ask her permission to help and assist. That's a lovely idea. That's not even on here. And I think that's a lovely way to respect her autonomy, to say, I'd really like to help. Can we have a conversation about this? Absolutely. Talking resources in the community. Awesome. Understanding her mental health history even more. Is she on meds? Did she stop them with pregnancy? Great thought. And we also know during pregnancy that the dosing sometimes needs to change and hasn't. Has she had a previous history? Awesome. Understanding her coping skills. You guys have it all. I think you literally have everything on this list. Let's just make sure. So making sure that she has support, including on your team. Does she live alone? We know that is a very big risk factor. So sometimes that can be not just in Janine's situation, but in any situation, someone on the lower risk. Can you get collateral? And can you also work with that person to arrange for them to have a bit more support? And limiting harm reduction in terms of substances, limiting access to means. So this is also where collateral information can be helpful. You would ask Janine directly, but then also asking the friends or family members what she may or may not have access to. All right, psychoeducation, communicating hope and reassurance. Hope is tricky. Some patients find that validating and some find it like, I don't have any hope, get lost. So, that's obviously you use your feelers, but at least providing the reassurance and that there is treatment. That might be a small sliver of hope for some people. Providing symptomatic relief. So we know anxiety, for example, and panic in particular, can really take somebody who's experiencing suicidality and make that almost unbearable. Starting treatment for depression, asking some of the great questions you guys have asked about, what has her previous history been, and taking the treatment from there. Looking at stressors and trying to understand those more, and also providing follow-up. I think this is really critical in primary care. in particular? When is the soonest that this person can be seen again, even if you're thinking they're at low risk? And of course, documentation, including actions to reduce access to means. This is really important, both for passing information on amongst the team and also medical legally. I'm just having a look at the chat here. Yeah, and ensuring they have crisis numbers. And someone else mentioned resources. So all super important. Okay, I'm going to just leave it on here for a second when we go to Jamal, because Jamal was more, and again, it's not like one thing flips you from low risk to medium risk to high risk, but moving up the risk scale, Jamal certainly had thoughts about suicide and had some serious risk factors, even though he denied an immediate plan. So there was no immediacy to it. There's no plan that he was acting on. What would you do in that, or in that case? Is there anything different that you would do than with Janine? So you're more worried about his risk. I would flip back, but I think it's like probably like 15, 20 slides ago. So this is the fellow who, yeah, closer follow-up for sure. Commitment to call, absolutely. This is a great time, and Diane, I know this is not what you're saying, but we often get questions about contracts. So like, you know, this used to be a more common practice, but like, I promise I will not end my life, or I promise I will come back, or I promise, however it's worded, there's no evidence that those help. But what does help is what you're suggesting, Diane. Just really having an explicit conversation about what the person will do, and then offering that close follow-up, but not giving yourself the reassurance that, okay, well, they've said that they won't, so they won't. But a written safety plan can be very helpful to people, especially one that's very specific and talks about actions the person will take if they do have more suicidal ideation, or there's more urgency. Okay, and I think that goes with what you were saying, Lori. Exploring means, plan, trying to get agreement to keep him safe in the short term. Yeah, talking about emotions as temporary. That's really interesting. There's a more psychological approach to it, but you know, on one hand, validating, while also, yes, I mean, that would be depending on the person, and you would try that out and see how it fit with them. But understanding that pain can also pass, and maybe even looking what the person other times in their life that pain has passed, or how have they coped. That could be a real entry for sure. Written plan, Sarah, thank you so much. That's exactly what I was getting at. So again, it's different than a contract, and written in particular is helpful, and concrete is very helpful. Okay, you'll reach out to someone. Who will you reach out to? How will you reach out to them? What will you do if they aren't available? Who can you then reach out to? So very concrete written plan about what they will do, and revisiting that plan with them in your close follow-up. So all great solutions. All right. Now it says here, request an urgent psychiatric consultation. And I'm sure some of you might be rolling your eyes, because how easy is it for you to get an urgent psychiatric consultation, which will really determine whether you can do this. So ideally, if you do work on an integrated team and there is a psychiatrist that you have available, this would certainly be someone to escalate to them. And you might have it in the back of your mind, or the front of your mind actually, when did Jamal move from moderate risk into high risk? And that's, we're going to talk about high risk in a second. And that certainly, if you can't follow up with him for some reason, or he contacts you again, or you know, is more plagued by planning, taking steps towards planning, all of those things would start to move him from moderate to higher risk. And then maybe you can't wait for the psychiatric consultation, and the person moves into higher risk, and they need to go to the emergency department. Being with his agreement, being in touch with family members, someone that he is in contact with. And limiting access to means that are very important, in particular in this higher risk group, because it can be very impulsive. People can move from ideation and plan into action quite impulsively, especially if there are substances involved, and especially in a younger age group. Okay, ensure the family also knows how to contact you. Again, providing symptomatic relief. So looking at those modifiable risk factors and seeing, maybe not even waiting a week, trying to see him the next day and then assessing whether he's kind of stabilized in the same place or has moved into a more urgent situation. Okay, and then having a crisis card. Oh, actually, I think, sorry, that's from the previous case, but very important. All right, so high risk. So somebody who has a plan, intends to act on it, or even I would say like a very vivid or detailed plan, or they've taken steps towards it, or they've had an escalation in their recent attempts. There are a lot of things that start moving people into, has access to means, and you can't actually reduce that risk. Those things are all, but the highest is imminence of risk. So they plan to go home and act on something, or they have means there and they won't grant anyone access to it. That kind of thing definitely pushes someone into high risk. And this is where, this is actually a very easy plan in a way, because it's really moved into the realm where people need care within a hospital. So emergency department, potentially certification, especially if they're not cooperative, or you think that they might be at risk of leaving. Any other thoughts about this high risk group? Because it almost makes it sound like too easy. Anything that, I'm just looking here. Anything that would complicate this for you in your setting, or where you would think it's not that easy? Attention-seeking behaviors, teens. Okay, this is often tough. So I do a lot of work in Nunavut, and a lot of it is indirect. It's with the primary care providers, in particular nurses in smaller communities. And this happens all the time, where they see someone who's definitely in that red category, but they're there a lot. Or, you know, there's the nurse happens to know about something in the community where like 10 teens are coming in and they would be in this high risk category. I think this really depends on how much you know the person, whether it's a youth or whatever the age, how well you know the person, whether you have follow-up with them, and whether you have contact with someone else in their family. That is tough, but often we are sending like 3 to 5 youth for assessment in the hospital. So it doesn't mean that they're not high risk. It just means that you're dealing with the practical problem of a number of people, or of one person being high risk. But definitely team-based care can help. Chronic elevated risk, history of personality disorders. So this is why, you know, when we have practices where we deal with people who have personality disorders, who have chronic suicide risk, working on a team is really helpful. Having a general plan, meeting with other members of your team and deciding, has it moved into that realm? Having a plan with how you are going to work with that person who is of high risk, including having a psychiatrist who gives their opinion. But at the end of the day, if you think someone needs to go to the hospital, that's often a safe approach. And then people get short assessments or short admissions. The other thing I would say about that group, because we could do a whole presentation on chronic suicidality and elevated risk. But one thing I find key, 2 things are key. One is working as part of a team and having a plan with that person, with the patient. And so that you know what their baseline is. And the second is, even if someone's at high risk, they can be at higher risk, and knowing what those times are. So if they've had a loss, if they've become unemployed or been rejected in some way, if they've had more attempts, you know, more lethal attempts, then they are at higher risk, and having them assessed at hospital is not unreasonable. But definitely, we often need support. How to transfer? Can we rely on the patient to go? What is the wait time in the ED? Those are all very practical challenges, absolutely. And you can always call 911 if you are having trouble transferring somebody. That and soon in November you can call 988 for that matter. Can we rely on the patient to go? And I think that's really the question around certification on using the Mental Health Act. And when in doubt, we always say, even in the emergency department of a psychiatric hospital, if you're in doubt, use the certification. It can always be lifted. And understanding the wait time in the ED, although it's not really your, it might be distressing for the patient, but if they need to be seen, they need to be seen. Janine, yes, same person. I think that's the chronic issue. Interactions or phone calls. How do we transfer them? Yep, calling an ambulance. I don't know about ambulance and ER. I would say if you don't have immediate access to the patient, the safest thing to do is to call 911. Like if you're interacting by phone, you or video, then calling emergency services. Like not the ER, but actual 911. Okay, wow, those are all great and very challenging questions, and wouldn't necessarily be easier for me, even if I was in the situation, or for Peter. Like those are the things that are really tough and continue to be tough. Okay, let me see what the last. Oh, and this is the infographic that the team has been working on. And I think it summarizes a lot of this. So we wanted to put it up just to show you that this is a resource that summarizes the things that we've talked about. And on the back, and when will this be available, Allison?
I believe it's finalized, if I'm not mistaken. Allison G can confirm in the chat, but if so, then we can share with everyone afterwards.
Yeah, I just realized that she probably can't necessarily just pop right in with speech. So thank you for that. But this will be available and summarizes the information. And on the back of it is also a list of resources. So I guess Peter and I are both happy to take questions for the last few minutes.
Yeah, and I wonder, thank you so much for that, Allison, but I wonder if people are even aware of the number and the national service. I think if you may want to just let people know what an how instrumental you've been in creating something nationally.
Right, sorry, and I did kind of assume that. So there is already a 10-digit. It's actually on that resource. So Talk Suicide Canada, there's a 10-digit distress line, national distress line. But as of November of this year, we're getting 988. And so we're busy implementing that. It will be the same Talk Suicide Canada service, but available through this 3-digit number. And we have collaborations with 911. It's a suicide prevention and distress line. It's not a mental health navigation line, but hopefully that will start to play more of a role in this landscape of people in distress.
Thanks. And I think if anybody can zoom in on that, you'll see that number is there in the green and the peach yellow box. But as Allison, you're mentioning, that number will change, right? There will be this number, which is the 1-833-456-4566, or a text messaging and calling 911. But you will have a 3-digit number, right? And there'll be a national sort of, we can certainly make sure we circulate it amongst our community practice, but is there going to be some national sort of advertising of that number, or?
Well, it's interesting. The Public Health Agency is talking about a kind of soft launch. I think it's not possible. As soon as it's out there, people are going to know. No. But it'll be 988 as of December 1st. Yep.
988. Okay.
Yeah.
So 911 and so 9988. Okay. And of course, if you call 911 by accident, I would imagine that they would just patch you through.
Yeah, exactly.
Okay. Great. Thank you. Thanks for that. I think that's, people know there's an immediate resource, while I think Allison Prasad was saying, we're going to finalize and make it available shortly. But in the meanwhile, if you need it, there's something there, the numbers right there. Yeah. So Jenna Dixon is asking a little bit more information about 988.
Yeah, it's essentially a crisis line, distress and suicide prevention crisis line. Yeah.
Yeah. All right. Can we open it up for other questions, as you said? I mean, we have some time, so 5 minutes. So any thoughts?
Susie, I saw Susie has a question. No, it's national, so it'll be available anywhere in Canada and routed to, it's a network of distress centers, so routed to the place closest to the caller's home.
Yeah. So basically, there are these warm lines, there are these distress lines in every province, including Ontario. It's just that this, talk suicide will be available and harmonize access across the country. And those provincial resources will continue. Yes? Yeah. Okay.
Yes,
So,
not every resource will be part of 988, but
okay.
988 is a network across the country. Yeah.
Yeah. The other, I know we've talked about this in the last 2 minutes. What support is there for a healthcare provider who might have lost a patient to suicide? What kind of thoughts, how should we approach that, and any advice?
Such a good question, Peter. You know what, who is it? Canadian Medical Association has a fairly new task force on suicide, and this has come up, but there's not, as far as I know, any unified like postvention for healthcare providers. It would be a great resource. Maybe we should talk later.
We should. I mean, generally what we have done is, if somebody has experienced a loss, we approach it the same way. We listen, we understand, help them process it. Typically as healthcare providers, we often reflect on what we could have done differently. We may feel guilty, we missed something. So we listen, and then we help the person sort of come to, realization about what they can do next about it. Maybe grieve the loss of the patient as well. But typically that's how we would approach it. But is there any other, I mean, that's kind of more common sense as opposed to any guideline. But in the meanwhile, if we don't have something, then,
Yeah.
that's
Well, just, I mean, I think there is that added complexity. Often, healthcare providers feel a sense of personal responsibility. Sometimes they're going through medical legal challenges. That certainly happened to me when I was brand new psychiatrist, and those things are very stressful. So yeah, there's not a formal process of.
Well, what I suggest is just, reach out to people who can support you through this, whatever happens. I think the people on this, and again, if you need us to, reach out to us, we can sort of brainstorm with you and figure out how to support you should that ever happen. So thankfully, these are rare events, but, when they do happen, they do cause us. And, and then the whole idea is, can we do something about this? And so this is our first attempt. So thank you so much, Allison, for taking time out of your extremely busy schedule to share your wisdom with us. And I think I can see the comments in the chat about how appreciative this is, and the fact that we had 1.91 people show up or more on a Monday afternoon. That's great. Between 2 and 3. That's amazing. So thank you. And again, thank you, Natalie. Back to you.
Yes, thank you both for such an important discussion today. We really appreciate the knowledge and expertise that both of you bring to this topic, and we had lots of great questions in the chat and engagement. So I know we're kind of out of time, but I do have a couple of kind of housekeeping items to go through. If anyone needs to head out, feel free to do so at this time. I'll just be going through a couple of reminders. All right, give me a second. So here's just the resources. There's a couple, we will be sending out these slides, so no worries if we weren't able to go through these today. And if you do have any outstanding questions for Dr. Crawford or Dr. Selby, please feel free to reach out to them through email. Their emails are up there. If a link to the evaluation and post-learning assessment will be emailed by the end of today, actually. So if you're interested in receiving a letter of completion, make sure to complete that by next week to get that. And then just an FYI about our teach educational rounds coming up in June, which will be on motivational interviewing. So look to our listserv and website and all of the other networks to find registration. That will be opening soon. As well, if you missed a portion of today's webinar or want to view it again or share it with others, an archive list is found on our website, so feel free to check that out. So for now, thank you all so much for joining today and participating. We hope you all have a great rest of your day. Thanks, everyone. Bye.
Thanks. Bye.
Thanks so much.
Thank you. Thanks.